Welcome to Legal Nurse Podcast. This is your spot to get inspiration, tips, stories, and guidance to help you in your legal nurse consulting practice. I'm Pat Iyer, the host of Legal Nurse Podcast since 2016. We are among the top 5% of all podcasts in the world in terms of longevity and sharing information consistently week after week with legal nurse consultants. Sit back, relax, and enjoy the show. Thank you for being part of the Legal Nurse Podcast audience. I'm delighted that you've joined us for this episode. Be sure to go to legalnursebusiness.com and get your free reports, look around the website, pick up some tools that will be useful for you in your legal nurse consulting practice. And be sure to join us for the next episode. Welcome to Legal Nurse Podcast. I am Pat Iyer and the host of this podcast. Today, I have the opportunity to bring to you a very well-qualified physician who is a pulmonologist, critical care physician, board certified in those areas, and does expert witness work. He has a deep interest in looking at the standard of care and looking at evidence-based medicine, which will be the topic for our program. He also has a great deal of expertise in a forthcoming textbook as an editor on the topic of pulmonary embolism, certainly a deadly condition, and does give rise to lawsuits and in terms of people suddenly dropping dead from pulmonary embolism. Something that I can remember, Charles, vividly as a staff nurse taking care of a man who I really liked, coming in the next day and asking, where was he? His bed's empty. His roommate saw him walk across the room, clutch his chest, and drop on the floor. And that was it. Done. And the roommate was feeling guilty because he thought, well, if I called the nurse sooner, or maybe something could have been done. And I spent some time reassuring him about the lethality of a massive pulmonary embolism, which is what the autopsy showed. Mm-hmm. I'm sure you've heard many such stories in your career.
Well, thank you for having me, Pat. Yeah, pulmonary embolism became a passion of mine because it is where coronary artery disease and stroke was about 25 years ago. Underestimated, undervalued in terms of how often it occurs, with little objective data and evidence out there on diagnosis and management. So being part of the PERT consortium and being one of the editors for this textbook, we try to bring forward all of the current state-of-the-art knowledge to allow people to understand better the approach, the diagnosis, and management of pulmonary embolism. And we feel that we've cornered the current state-of-the-art. However, there is a long way to go.
And I should formally introduce you as Dr. Grodzin, a person I've known for many years as an expert witness and have referred cases to him. He is the co-editor of the upcoming textbook on pulmonary embolism response team, the consortium, and it is a handbook on pulmonary embolism research, management, and care. Welcome to the show.
Thank you for having me, Pat.
Our focus today is on evidence-based practice, a term that is somewhat murky and one that many legal nurse consultants and attorneys focus on in the hopes of coming up with precise definitions of what exactly people should do. So first of all, let's talk about what does that term mean and how do the providers integrate evidence-based practice into their daily work?
Well, evidence-based decision-making is the analysis of clinical complex problems for patients, wherein decisions are made based on what we understand from data, that is generated from the literature, from studies, from uh, um, past uh, understanding of medical conditions that we all, from a medical community standpoint, can agree upon. We agree upon them because they've stood the test of time and have been proven over and over in medical research and disseminated in literature. It is the type of approach that we teach to medical trainees, whether they're medical students, residents, or during fellowship training, as a way of communicating our thoughts and decisions such that we all are on, quote unquote, the same page. Um, there, uh, from the start, isn't enough experience on a personal level to have seen enough of a certain type of clinical case to make decisions that are independent and outside of the general literature experience. The way that we've always approached it, whether you're in training or whether you're in private practice, is that as time goes by, your clinical experience grows, and you may see a clinical situation more than once over time and understand it. And at some point in the future, your experience of treating that problem becomes a pattern. But the basic understanding of disease processes, why we do clinical studies, why we do research, why we put it in books, why we publish articles, why there are peer reviewed journals, is so that we can compile a common understanding of disease process and apply those over and over again in similar clinical situations.
You bring up a point and remind me of a case that I worked on with a young woman who developed choriocarcinoma after delivery. And one of the points in this case was that there was a delay in diagnosis, and by the time it was diagnosed, it was metastatic. Mm-hmm. The obstetrician argued in his defense that this is a rare condition, and based on his years of practice and the number of patients he had seen, he had never encountered this before. And the defense argued you can't hold him to the standard of care because it is so rare. It wasn't a typical postpartum problem that would come to mind. Ultimately, the jury did find him responsible and awarded $4 million for her extensive pain and suffering over the last 2 years of her life. And that's how I came in, summarizing 25,000 pages of medical records. But it brings me to the question of those rare conditions that you alluded to before. How does evidence-based practice fit into this when it's something that a provider may never have seen and might finish his practice working as an obstetrician and never encounter again?
Right. Well, there's always the responsibility as the amount of literature increases over time to quote unquote keep up with things. So that even though we as individuals may or may not have seen anything in the past, the nice thing about an evidence-based background is that it's out there if you take the time to pursue, read, learn, and keep current with even things that we see and even things that we don't see as much. So someone has seen it. That's the nice thing about the evidence-based background, is the fact that because we are understanding that we are individual physicians, but that we work as physicians as a whole within our specialties, we're providing information and knowledge for other people at the same time as we provide it for ourselves, as we learn about conditions, syndromes that we may or may not run into on a regular basis. Certainly some things are more common than others. And it may be easier for things like diabetes or heart disease that we see all the time. The more rare situations, it's just a matter of using the knowledge that's been generated to incorporate that into our practice patterns. The problem is that if one operates outside that evidence-based realm, that you're basically kind of paddling in the ocean by yourself, and you won't have a perspective to take advantage of. You won't have a knowledge base to take advantage of, and the decisions you make may or may not be right, depending on what your personal experience with that situation is. So even if we haven't seen things ourselves, There's a body of knowledge and a body of literature, and actually in 2025, access to that because we have a significant electronic background of knowledge and access is much easier than it used to be. We may have had to go into say example, textbooks or the library and try and pull all the information on something unusual. But these days, with electronic media, we have such an easier time obtaining information about even things that are more rare that we personally haven't seen or see very rarely.
That's a great point because our ability to access literature has changed dramatically.
Hmm. It
I
has.
have been in nursing long enough, and I know you've been in medicine long enough to remember the physicians who said, I'm not going to follow cookbook medicine. You're not
Hmm.
going to tell me what to do. How does that relate to evidence-based practice? And what did you say, assuming you were part of that discussion, what did you say to those people who said, nope, I'll do it my way?
Well, it's regrettable that an individual would have a perspective that their way is the only way. There may have been a time when access to knowledge and the opportunity to broaden your knowledge base was so difficult that you had to rely more on experience, more on your own perspective. But that has changed dramatically, even during the years of my practice and into this electronic age where now, if you wish to treat a certain syndrome differently than the evidence as a whole suggests, you're basically taking a risk. And in my personal view, taking a risk is not in the best interests of the individual patient. The patient benefits from the knowledge that's brought to a certain situation by the many, many, many people who have spent time gathering that information, producing state-of-the-art literature, doing studies, publishing books and journals, and that patient benefits from, depends on your willingness to accept the fact that there are certain ways that have been proven to be successful in treating certain problems. I don't think a patient wants to know that that kind of knowledge base is out there, but I'm going to do it differently. I'm going to do it my way. And my way, again, isn't backed by anything other than my personal perspective, which is far less than the body of knowledge that's out there. I think patients want to be treated based on a collective understanding of their particular problem, the support not only of their knowledgeable physician, but the support of the medical community as a whole.
And the people who are making those decisions are the jurors, if a case should get all the way to trial with this type of a scenario, where you could expect that they would have the opinion that you've just shared. Yes, I appreciate this doctor's care, but I expect the doctor to do the right thing according to what medicine says you should do.
Yeah, and I think it's important to recognize really that the standard of care, quote unquote, really carries with a message that the standard is a standard because it is something shared by medical community in that particular clinical context of whatever's going on with that individual patient. Something that's very unusual or a strange approach to something doesn't benefit from that shared clinical context and doesn't really commingle, or isn't congruent with what what the feeling of what the standard of care really means.
And I think we should probe this a little bit because there are facilities that don't have the resources to be able to provide care according to the evidence-based information that's available. My husband and I last week were at Johns Hopkins for his twice a year GP evaluation. And I know that Johns Hopkins, as a tertiary hospital in Baltimore, has resources far different than a community hospital in a small town.
Mm-hmm.
How do you reconcile the differences when you're evaluating the standard of care and evaluating evidence-based practice between the community hospital that is just doing their best but doesn't have interns, residents, fellows, and the whole advanced set of diagnostic tools that a large tertiary hospital might have?
Right. Well, so a couple of answers there. First of all, in the past, there was a larger, certainly both a geographic and knowledge base and experience difference on smaller hospitals that are perhaps in rural circumstances, and the large universities that are a collection of academic physicians who do the research and produce the literature. Obviously, with the electronic world that we're in now, that gap has narrowed, and there is much more access to what's generated for the knowledge base, and creates, an evidence-based perspective for everyone. With the advent of the internet and such, I can access medical libraries, I can access journals, I can access everything in the same way that someone at Johns Hopkins or some larger medical center can, number one. Secondly, again, there is a responsibility to, keep current with medical knowledge, regardless of what your subspecialty is. And some of that is taking advantage of the basic knowledge base that's out there, and doing the best you can. Uh, if a clinical problem exceeds your personal capacity or the capacity of your institution, let's say, for example, that a patient requires a procedure that's not offered at one hospital, it behooves the smaller hospital to have a standing relationship with other institutions that can carry out the types of procedures that are necessary, sort of like in a hub and spoke type model, for example, where if a certain surgery is needed and you don't do it at your facility, that you know where it can be done, you have contacts that you can contact, administrations can transfer patients, and patients can get the type of care that they need. Are there circumstances where that's not feasible? Probably so. And in those situations, the standard of care has to represent the fact that you've done everything you can do, to provide the care the patient needs. And if there is an unmovable object or some type of obstacle that you can't get by, or there isn't time to get someone several hours away or a means of doing it, then the standard of care needs to also be flexible enough to understand that the best motives of the physician were to take care of that patient the best that was possible in their circumstance, and not judge them against an environment which is not comparable. So this is one of the types of perspectives as a medical expert, looking at legal cases, that you have to keep in mind. So that has changed over the years, as I explained. But the object of how I look at a case is to be initially objective, always objective, represent the medicine, advocate as an advocate for the appropriate medical care, and then look more specifically at whether or not there are any obstacles that were, let's say, insurmountable in the application of that care, and understand that when people are trying to do the best they can, it shows through the medical records.
Have you ever seen in reading deposition transcripts where attorneys are asking, what resources did you touch or tap in order to determine what you should be doing for this patient? And I'm asking this also in the context of having heard last year about increasingly AI programs being used for diagnosis and treatment purposes. And as we talk about this, it's popping up in my head. I'm assuming that they have built in evidence-based practice into those tools. I asked you two questions, which I know as an expert, you recognize. Question one, question two. Question one was, do you ever see attorneys ask experts, or ask defendants, I should say, and also potentially experts, what information do you rely on to establish the standard of care when it comes to evidence-based practice? And then secondly, the role of AI
Yeah.
in this process.
Yeah, for sure. I've definitely seen, the questions about how decisions are made. Basically, is what we're getting at. What kind of either background or information or source was used to make a certain clinical decision in context. And of course, as I said, that can matter quite a bit. From my standpoint, I want to know whether the person, and I generally, am familiar enough across the board, to understand when a decision-making process has been evidence-based or not. From the standpoint of AI, AI requires the same rigorous research and literature development that any clinical procedure would require, whether that's a medicine or a surgery or a certain type of catheter of some sort. We have AI in pulmonary embolism from the standpoint that there are uh, uh, software programs that will read CAT scans, CT angiograms of the chest for the purposes of identifying pulmonary emboli even before the radiologist has seen the CAT scan, and will generate a response message to the pulmonary embolism team that a pulmonary embolism actually has been found. Here's the patient, here's where they are. In fact, some of them will include the images, the vital signs that can come to an app on your phone or computer. And for the point of hastening the diagnosis and management, for that patient. Um, so from an informational standpoint, AI is becoming a useful colleague in the diagnostic process, but the use of it has to be accompanied by um, the same rigor that has gone into any type of diagnostic test, whether that's diagnosing your gallstones or a hernia or a tumor of some sort, uh, as anything else has. So we don't accept it, based on the fact that it's new. Um, we accept it based on the fact that it's been again proven and then incorporated into the evidence-based paradigm going forward as having a role in the diagnosis and management um, for pulmonary embolism, for example, in the case that I'm talking about. But certainly, there are also AI programs for aortic dissections, for intracranial hemorrhages, for a number of other uh, clinical syndromes. Wherein the faster the diagnosis, the earlier the therapy. Generally, the more successful the therapy, the better the patient outcomes.
Have you heard about LNCEU? LNCEU is our multimedia, in-depth, never leave your home programs. This is a way for you to receive the best content for expanding your legal nurse consulting business and skills. In this program, you receive 2 videos or a video and a book that I have written that will expand your knowledge base. The content is customized whether you are a new LNC or an experienced LNC. This is like the Book of the Month Club, except that you receive trainings that you can watch on your own time, on your computer, or on your mobile device. What you can use this knowledge for is to become the logical choice of a legal nurse consultant in your market, to obtain new clients and more cases, to increase your skills, and stop wasting your time trying to figure out things alone. The program is also accompanied by a new feature, which is open office hours, which I run once a month, giving you an opportunity to ask me questions and get answers to the things that are bothering you right now to overcome the challenges that you're facing in your business. I invite you to join LNCEU by going to this link, lnc.tips/LNCEU. Once you're on that page, you can choose whether you are a new LNC or an experienced LNC, and whether you'd like to pay for an annual fee and get a discount to get 12 months of content for the price of 10, or you want to pay monthly. I'll see you at the open office hours. Please join us in LNCEU. Speed is so important, isn't it, in so many aspects of our life?
Yeah, it is. But, the velocity at which the data travels is so much faster now than it used to be. Um, the pulmonary embolism artificial intelligence software can alert the pulmonary embolism team, as I said, just as the patient's out of the CT scanner, before the ED doc knows, before the radiologist has read it, and can bring us into a scenario where we can provide clinical care, not just for PE, but for a stroke or acute coronary syndromes, the things that are life-threatening, the things that, as you said, the sooner we find them, the faster the treatment can be applied, the better patients do. And I really believe that that's a significant new factor in taking care of people.
Which then brings me to the point of when plaintiffs feel they have not been taken care of appropriately and seek out an attorney, and the attorney calls you up and says, "Can you review this case for me, doctor? And I would really like it if you could find that the defendant created a delay in diagnosis or misdiagnosis." How do you deal with the attorney who wants you to see the case their way and implicitly or explicitly ask you to set aside your objectivity and fall in line?
Well, the first thing that I make clear, whether it's posed to me that way or just in general, if someone asks me to work with them, is that I have no side in this particular situation. I have no horse in this race. I will tell you the medicine. I will tell you objectively what happened. I'll translate the sequence of events. I'll translate into whatever terms we need so that you understand what a diagnosis is and what the disease process is, and et cetera. And I can tell you a timeline, and I can tell you a lot of things about, what has happened from my perspective. But I will objectively tell you my feelings at the end, one way or the other. But it has nothing to do with who you are, whether you're for the plaintiff or defendant, or what you ask me to do in terms of seeing things in one direction or another. That's not my role, and I will not, take one side over the other. My role is objective advocacy for the medicine, one way or the other. And it's also objective advocacy for the patient. And the only thing that I really want to make sure is that I understand what happened, that I communicate clearly with the attorney as to the sequence of events, um, the definitions of certain terms, for example, the presentations of certain syndromes. And if you feel, based on what I've told you, that there is a case from your standpoint or not, that's not my business. I'm not here to, be, litigation sensitive one way or the other. I'm just here to be a medical expert. The legal component is up to you, and and you know, um, you can make your choice based on what I tell you as to whether you go forward with something or not.
I have the sense that you have given this speech a few times.
It happens. It's and it doesn't happen so much that someone really tells you, "I want you to find things this way or that way." I wouldn't get involved with someone who put it to me that way over and over again. Um, I need to see what I explain is that if at some point I need to sit and give testimony, that I have to give testimony to my expertise, which is the medicine, not the legal expertise per se. And if someone's going to ask me questions about what happened here, you know, you know, what should be the timing of this? What's the right antibiotic? Should they have used heparin or Lovenox or something like that? Those are medical facts that I can opine to based on, again, evidence-based training and evidence-based knowledge. But that's as far as really I can go. The determination of whether or not there's a legal matter is not something that I really, have the expertise for. The only thing I can do is tell you, based on my experience, that the medicine said this or said that, and then the process of whatever happens from a legal standpoint is a process that goes forward, after that point.
And before I ask you my last question, as you're discussing the importance of the expert being objective, being able to withstand cross-examination, and being convincing in the courtroom, we both know that there are experts who are less filled with integrity. I'm trying to think of the right word.
Scrupulous, I think.
Scrupulous. Yes, I like the word scrupulous. And that there are times, it certainly happened to me, I'm sure it's happened to you, when colleagues have said, ew, you work with attorneys? Why do you want to help them? What's going on with that role? How do you explain the nature of being an expert to your colleagues who are questioning your integrity or your scrupulousness by
Right.
being involved in this litigation?
Well, my scrupulosity or my integrity is based on, again, I think when you define the terms, it's much easier to operate in this sphere, that I will always only interpret the medicine. And so from that standpoint, my integrity remains intact because that's only what I will do. If I was to lean over the edge and say, this is what happened, and I think, this guy deserves to be sued, and then I'm getting out of my lane, so to speak. And I try to respect that patients deserve advocacy for their medical care one way or the other, whether I'm their primary physician or whether the physician who's taking care of them is treating them correctly or incorrectly. Um, and that still falls within my sphere of expertise. Advocacy for the truth and bringing things out into the sunlight, as they say, is sometimes the best disinfectant of really understanding things. That's pretty much what I try to do, is to bring things out into the light and stay within the lane of a medical expert and let the attorneys do what the attorneys do and the jurors do what they do and the judge do what they do and the depositions be taken. But patients who are exposed to physicians that harm them, those individual patients or their families deserve advocacy. When physicians are wrongly, alleged of something, the physicians deserve advocacy. There is a right way of going about being a medical expert, respecting the role of the physician, staying within your lane, um, advising on medical issues only, and providing the same sort of approach, whether you're, being, you're working with the defendant or you're working with the plaintiff. None of that matters. You're going to get the same story from me, whoever you are. In fact, sometimes, maybe I shouldn't admit this, but sometimes I forget whether or not, when I'm in the midst of a case looking through medical records, who I'm working with, defendant or plaintiff, largely because it doesn't matter, because I'm going to see what I see. And, that's going to get translated into the communication I give to the attorney. It doesn't really matter which side of the ledger you're on as far as that's concerned. The medicine will speak for itself through someone like myself, who again remains steadfastly in the role of a medical expert, um, remaining objective, using evidence-based understanding, and trying to preserve the the sanctity of the role of the medical provider for our community, our world community in terms of really presenting medicine at its best.
We've covered a lot of topics today, and I suspect that there's somebody listening who says, I need him on my case. What would be the best way for them to reach you?
Probably the best way to reach me is through email. So my email is just cgrodzinmd@gmail.com, which is cgrodzinmd@gmail.com. I respond to email. I don't have a website or anything fancy like that. I currently practice as well. So for anybody that's interested in knowing that I am an active pulmonary and critical care provider, both in ICUs and in outpatient settings. So in the midst of my practice, I have found that being a medical legal consultant to be a very satisfying role for many of the reasons that I have explained during our discussion. But yeah, I'm happy to talk about cases. I'm happy to review cases. I'm happy to again give you my 2 cents objectively, regardless of the circumstances.
Well, thank you so much, Charles. I appreciate the chance to talk with you about this topic. It certainly is one that looms large in medical malpractice cases when we're looking at the standard of care. And in hindsight, retrospectively, evaluating what happened and how that fits within the legal system, if at all.
Correct.
I know you've stressed that there are physicians who are unfairly accused of being negligent, and our role in that case is to make sure that attorneys are not spending their precious resources litigating cases that have no end path, no chance of success for particularly the plaintiff attorney who's putting out all that money with no chance of return.
Right, right. If I'm presented a case and go through it, either in a discussion or medical records, yeah, I believe that my feedback will help attorneys make the right decisions about what to pursue and what not to pursue. Not because I convince them otherwise, but just because I share a clear understanding of the medical information, which often can be confusing and can be hard to understand. Often it's in a different sort of language. There's a lot of terminology. There's a lot of nuance. There are a lot of subtleties. Um, Having experience as I do, I feel like I can bring those into the light and make them clear and understandable so that whoever is making a decision on what to do next makes the right decision. To me, that's a very satisfying outcome.
Yes. Yes, indeed. Thank you for being a guest on Legal Nurse Podcast. I appreciate you.
Thank you very much, Pat. It was a pleasure for me to be here and talk to you.
And for you who's listening to the show or watching it on our YouTube channel, which is Legal Nurse Business, be sure to hang on for another few minutes to find out what's coming up next and go to legalnursebusiness.com. We have a whole new variety of special reports and resources for you based on whether you are a new or an experienced legal nurse consultant. I'll see you on the next show. Coming up next on Legal Nurse Podcast, you'll have an opportunity to get a bird's eye view of the role of the medical case manager. Our guest is Larry Boyd. He's an RN with extensive clinical experience and extensive experience as a case manager. Larry, tell our listener, what are some of the key topics that we talked about in your podcast?
Sure, Pat. What we talked about was the differences between a medical case manager and a legal case manager. We also touched on the certified case managers, the importance of using those. We discussed who pays for the case manager, who would hire that case manager, and then how the case manager could be of assistance to a legal nurse consultant, whether in-house or an independent LNC that's working. Other topics we discussed about were some of the qualifications to become a certified case manager and some of the differences that you may run into when dealing with case managers who are certified versus non-certified.
Thank you. We covered a lot of territory. Coming up next on Legal Nurse Podcast. Welcome to Legal Nurse Podcast. This is your spot to get inspiration, tips, stories, and guidance to help you in your legal nurse consulting practice. I'm Pat Iyer, the host of Legal Nurse Podcast since 2016. We are among the top 5% of all podcasts in the world in terms of longevity and sharing information consistently week after week with legal nurse consultants. Sit back, relax, and enjoy the show. Thank you for being part of the Legal Nurse Podcast audience. I'm delighted that you've joined us for this episode. Be sure to go to legalnursebusiness.com and get your free reports, look around the website, pick up some tools that will be useful for you in your legal nurse consulting practice. And be sure to join us for the next episode.